主任，我们先抓紧时间把最后一个讲题讲完，我们再讨论，好吧？最后我们还有一位讲者是来自美国 UPMC 的 Professor Danny 楚，
看得到。
嗨，
你有没有听到？
哦，能听到，楚教授，您说。
谢谢，很感谢你们邀请我中文不太会讲，可是我会听很多。我是中国人，在台湾出生的，谢谢。
好的，欢迎。
谢谢。
Sure.
Thank you.
Now, because they have the slides ready, so shall we have the presentation first? 我们先听他的那个 presentation 再讨论。好了吗？
好，谢谢。About diseases in young adults.
Okay.
These are my disclosures. Specifically, I want to disclose that I am a consultant and an international proctor for the Japanese Organization for Medical Device Development, who is the company that makes the proprietary products for the Ozaki procedure. Otherwise, no relevant disclosures. As you all know, Professor Ozaki in Japan refined and pioneered the aortic valve reconstruction for a standardized technique in 2007. Namely, he utilized the autologous pericardium, fixing a 0.6% glutealdehyde solution, and used a proprietary template to cut out 3 leaflets and perform a tri-leaflet aortic valve reconstruction or neocuspidization to treat all types of aortic valve diseases. In 2018, Professor Ozaki presented at our premier American Association for Thoracic Surgery and published in the Journal of Thoracic and Cardiovascular Surgery his 10-year experience of over 1,000 patients. The results are excellent, and it has greater than 95% freedom for reoperation in 10 years, which I will show the data a little bit later on. Specifically, this procedure is very attractive for younger individuals. In 2014, Professor Ozaki published in the same journal, Journal of Thoracic and Cardiovascular Surgery, his case series of patients who are less than 60 years old. And the results are excellent. As you all know, patients who are younger tend to have an increased rate of structural valve degeneration when implanted with a tissue bioprosthesis. However, in his series, the Ozaki procedure series, he looked at a total of 108 patients who are less than 60 years old with a mean follow-up period of 34 months, and the freedom for reoperation in this series of over 7 years was 98%, which is quite impressive. And this is the data and the graph from that particular publication. Moreover, this technique is very attractive for patients with hemodialysis as well, as seen in this publication in 2013 at the Interactive Cardiovascular and Thoracic Surgery, where Professor Ozaki looked at 54 patients who were hemodialysis dependent, who underwent an Ozaki procedure with autologous pericardium. And the follow-up was approximately 5 years. It's a relatively short midterm follow-up, but what's remarkable is that these patients have minimal calcification even for 5 years. As you all know, people with hemodialysis tend to form calcifications on prosthetic tissue valves. Now, why is it that the results are so excellent? Well, I have my theories, and these are the following. It is essentially a stentless valve replacement technique. Therefore, the hemodynamics are excellent. With low transvalvular velocity after the surgery, that translates to low gradient, and laminar flow. And we all know that patients with bicuspid aortic valve with turbulent flow tend to have increased calcification. And this is also autologous pericardium, which has minimal foreign body reaction to form calcium. So, in my opinion, I believe that young patients who desire a tissue valve with small annulus and a large body surface area are ideal for this procedure. And especially patients with endocarditis who you want to avoid foreign body using autologous tissue. I will start by presenting a patient who I recently operated on. It's a 36-year-old male who presented with shortness of breath. Young patient, but does not want anticoagulation due to an active lifestyle. He also wants to have more tattoos, which obviously causes more bleeding, so he does not want to take anticoagulation. The examinations are pretty straightforward, no obvious concerns. The TE shows a severe aortic regurgitation with an annulus of 28 millimeters and normal coronary artery and the aortic root dilated at 44 millimeters. So the treatment options are the following. We could perform a Ross procedure, aortic valve repair, or a surgical aortic valve replacement with a tissue valve, or a Ozaki procedure with aortic valve reconstruction. The patient decided to proceed with Ozaki procedure. In the operating room, I identified a pulmonary root to be also dilated at 44 millimeters. Therefore, I did not think that the Ross procedure was ideal for this patient. The aortic valve repair was not ideal because the left and non-coronary cuspid were severely retracted. Therefore, I performed a trileaflet aortic valve reconstruction with autologous pericardium or the Ozaki procedure. Came off of the cardiac point bypass with no AI, mean grading of 3 millimeters of mercury. These are the intraoperative, preoperative transesophageal echogram before the operation. This is the long axis before the operation. After surgery, this is what it looks like in the oblique axis. You can see with minimal aortic insufficiency. This is the long axis after the operation. You see the reconstruction with no aortic insufficiency. Recently, we presented our data in Pittsburgh at the Society of Asian Academic Surgeons. We have now currently close to 100 patients with excellent outcome, with no permanent pacemaker and no mortality. Specifically, the freedom from moderate AI is 90% in 5 years. And the freedom from greater moderate AI is 100%. Overall survival is excellent in our series. We currently have the largest volume of adult Ozaki procedures in the country. This is the figure comparing Professor Ozaki's series in 2018 with a very popular valve across the world, also in the United States, at the Abbott or the St. Jude trifecta tissue valve. And this is the data from the Abbott itself. As you can note, the freedom from reoperation was greater than 95% Professor Ozaki's series, and in Abbott or the trifecta tissue valve, the freedom for reoperation was only 87% in 10 years. Clearly, the Ozaki procedure wins in this comparison. Expectedly, the long-term survival at 10 years is also better in the Ozaki procedure compared to the trifecta or the Abbott St. Jude tissue valve, as noted by this graph. So the advantages of the Ozaki procedure is obvious. One is autologous procedure of autologous tissue. Two, it's very cost effective, so it's an ideal operational procedure for countries who are low to middle income. It has excellent 10-year outcome. It's a potential game changer in the next couple of years. Since Professor Ozaki started procedure in 2007, we will have data, 15-year data in the next couple of years. Some of the contraindications, whenever you have a dilated annulus, dilated sinus, or lack of usable pericardium, I will be cautious about doing this procedure. Therefore, to conclude, The Ozaki reconstruction is feasible alternative to a bioprosthetic tissue valve for replacement for all aortic valve diseases in young adults. These are my references. And we currently have a center of excellence in UPMC in Pittsburgh. We're happy to train any surgeons from the country across the world for this procedure. This is my contact information, and feel free to email me, send me questions. I thank everyone for the presentation and the opportunity. 谢谢大家，我很感谢你邀请我来，谢谢。
Thank you。朱大夫，他们还需要一点时间，准备那个 video 时候，我们先讨论一下其他的问题啊。
没事，可以，谢谢。
那海波主任在啊，还有唐院长，我们要不先问一下，我先问一下关于这个 Ozaki 手术的问题啊。唐院长是
可以，
也是一个非常有这个领域，因为从当年的那个 Carlos Duran， 然后一直发展到现在，这个技术这么多年了。那我想问，我先问一个问题啊，海波不知道熟不熟悉那个，海波主任不知道熟不熟悉那个 Duran 的技术啊？那我问两位，就是当年的 Carlos Duran 他用的这个方法，我那个时候很小，我还是个住院医生，我记得我们在长海医院去参观老先生做手术嘛，看他开的挺好的，但是后来就是效果都不好。那么当年他的方法和现在我们用的方法主要的区别在哪里呢？这个，
我觉得 Carlos Duran is a very experienced cardiac surgeon. And I think the difference, in my opinion, the difference between Duran's approach and Professor Ozaki's approach is the redundancy of the leaflets. Redundancy. And the fact that Professor Ozaki made it standardized. So if you look at the Ozaki technique, the zonal coaptation is always greater than 15 millimeters.
Yeah.
Which is tremendously bigger than the native aortic valve. Yeah. Now, Carlos Duran's approach didn't work because he was trying to make the aortic leaflet more like the native leaflet. Mm-hmm. So the redundancy is less. And when it's less, it becomes more challenging and technically more difficult. And I think from a technical standpoint, that's the reason why Professor Ozaki's technique is so reproducible, because it's so redundant. And I will tell you that I'm not a congenital surgeon, but I work with the Boston Children's surgeons a lot. If you talk to Chris Baer and Pedro Del Nido, the congenital surgeons, when the zonal coaptation for the aortic valve is greater than 15 millimeters, sometimes you could get obstruction of the coronary arteries. So,
right.
And I believe that Ozaki technique is going to evolve for younger pediatric patients. But for adults, it's a very reproducible and standardized technique. And we recently published in the Annals of Thoracic Surgery along with Marcus Koenig and Professor Rudiger at the German Heart Center, a review article specifically addressing this issue. It's been published in the Annals of Thoracic Surgery. So that's my opinion. I'd be curious on others.